For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 4, Episode 10 of Surfing the NASH Tsunami. Our look at pediatric and adolescent NAFLD and NASH starts now.
This week on Surfing the NASH Tsunami.
We're talking about maybe 17 to 25% of adolescents with fatty liver disease. This is not just NAFLD. These kids actually have NASH, and many of them have significant fibrosis.
These things are societal, and when you make an impact, it has to be the family affair.
But by the age of 13, there have been 72 million data points collected about that child. Advertising for use. How do we even cope with that?
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jarn Schottenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guests, hepatology researcher and key opinion leader Dr. Naim Alkhouri, and pediatric gastroenterology and hepatology researcher and key opinion leader Dr. Rohit Kohli, as they discuss pediatric and adolescent NAFLD and NASH. This week on Surfing the NASH Tsunami.
So it's been an eventful week for me. If you can hear this, my voice is a little scratchy. I'm hoping it will make it through the episode. If not, got great people with me to carry the episode in my absence, people who've done this a lot before, and one first-time guest who can talk about just about anything that could possibly come up because of the breadth of his experience publications. So let me introduce everybody to Dr. Rohit Kohli. Rohit, how are you today?
Good. How are you, Roger?
Except for my throat, I'm fantastic. 90, or as I like to say, 98% of me is just great. The problem is the 2% is what you can hear, so apologies for that in advance. And Rohit was good enough to join us today for this topic. Along with him, we have Naim Alkhouri, who's our other guest for the day. Naim, how are you doing today?
I'm good.
Working my way west to east, we've gone from LA to Phoenix, and now we have to go way east from there, jump the pond to go all the way to England. Louise, how are you doing today?
Very well, thank you very much. Nice to see everybody.
Good to see you. You're wearing kind of white and off-white today, huh?
Yeah, grey and white.
No Liverpool red. I understand.
Rather like the clouds today.
Yeah. And then continuing further east, we go to Germany and we get to Jarn Schottenberg. Jarn, how are you doing today?
Hi, Roger. I'm fine. Great. It's been a long day and coming to an end with me for this podcast.
Excellent. So, Rohit, why don't we do this? Since you're a first-time guest here, please take a minute or two, tell our audience a little bit of what you do right now and the path you followed to get here, and then wrap that up with one fact that people wouldn't know or necessarily suspect about you if you didn't tell them. And I should tell you in advance, we've had some pretty interesting answers to that question. Recorded musicians like Naim, professional athletes like Mazen Noureddin, who played basketball in Syria. Might be a little hard to visualize, but he did. And then some stories that are even crazier than that. Louise's favorite, I think, being Neil Anderson in gold lame shorts at a talent show. You don't have to match that one. Just do the best you can.
Well, first of all, thank you for having me. I'll start with the last request you had, which is tell you about something that is interesting. I think it's the most non-interesting that I can share about myself, probably is the most interesting, which is I'm a scum-sucking administrator. That's essentially what most of my job is now. I spend about 60% of my time in administration, whether it's research administration or clinical administration, but it is also the most fun part of my job because now I help others with their careers and their development professionally. I started as a clinician scientist, pediatric hepatologist by training, thought I'd cure the world, help children who have liver disease with liver transplants, and I have done so, but discovered along the way that there are things that we still need to understand. That's where science comes in, and that's where we put the worlds together.
Succinct and really nicely done, so thank you for that. With that, why don't we just go to icebreaker, and then we can kick off the conversation. One good thing, personal or professional, has happened in the last week?
I'll go first. It's been a very busy week, several meetings. I was in Boston, Denver, and San Francisco, all related to liver disease. So exciting to see all the activity, especially, 2023 is the year of NASH. Hopefully by the end of the year, we'll have one, maybe two FDA-approved NASH drugs. So a lot of good things are happening. We're also gearing up for the Desert Liver Conference. This is happening on Saturday in beautiful Scottsdale. I just got the numbers of attendees. We're up to 210, sponsored by many of the pharmaceutical companies, diagnostic companies in NASH. And it's also open for virtual attendance. So anyone listening, you still have a chance, even if you didn't make plans to come to Scottsdale to attend virtually. You can go to desertliver.com and then that will take you to the registration page. So this is my life for the next few days, is Desert Liver Conference.
Very exciting. Congratulations on the attendance. I know that's way up from last year, right?
Yeah, almost double.
Excellent. Congratulations. Next.
Oh, I'll jump in next. I attended one of the few Premiership football games that I've managed to get to this season, which was my B team, Crystal Palace, versus my A team, Liverpool. And we got a ball draw. So happy on both accounts, given Liverpool's were 2-0 up to lose 5-2 to Real Madrid a few days earlier. And Rohit nodding his head there suggests he might be a soccer fan. So we're going to find out, I'm sure.
It's actually football. It's what it is, right?
Yes.
Yeah, we play it with the feet, not the hands.
but Arsenal is my weakness, but it's okay. We'll agree to disagree.
And Roger invited you on, being he's a Tottenham.
Oh, it's about to get a lot worse, Rohit. I'm a Tottenham fan.
There's always a lot of football talk.
My apologies, guys. I did not know this fact about Rohit. Otherwise, I would have acted differently.
Rohit actually is now the second Arsenal fan ever to come on this podcast, and a lot more tasteful in describing his Arsenal fandom than the first one, who still occasionally text messages me to tell me how depressed I should be. Go ahead, Rohit. You could have made that your interesting fact, by the way. That would have gotten quite a reaction, but go ahead.
I didn't know the background of this group, and now I know. I think the last 2 weeks have been really family time for us. I had my sister visit from India, my wife's brother visit from Dubai, and in all the middle of this, we moved houses. Can you imagine that? I've had little time to breathe other than that, but it's been fun.
That's a lot. Okay, Jorn?
Yeah, so I was distracted a little bit. I was just surfing for the Desert Liver Conference, obviously. Naim, thanks for flagging that, and I'll be signing up, so good for the heads up. I had a great weekend. Saturday, I went to Berlin. We had a meeting on liver cancer. They asked me to actually review the evidence to screen for liver cancer and NASH, which is something you can discuss if you're in the cirrhotic arena, but these cases we're seen occasionally in the non-cirrhotic, and that's tougher. And the Germans tend to take a very liberal recommendation on the screening, so our guidelines actually reads that you could do it. If you look in EASL and ASLD, it's pretty clear that the cost effectiveness has not been shown. That was a good discussion and a nice presentation on Saturday, and Sunday I came back and we had family time like Rohit did with his family, just spending a little bit with the girls. That was great. And I just learned that somebody is worse with booking flights than myself, so I'm not going to give it away who it is, but that cheered me up.
Jorn, I'm not going to give it away that there are two of us who are worse than you, because then I would have to, thereby acknowledging that I'm not the one you found out about, but that it's true for me as well. What is the percentage of HCC that comes in advance of cirrhosis?
Yeah, so that's a good point. I don't think that's systematically looked at. It means you would have to look at all the cases, right, and do systematic screening and identify them. The number that's important from the health economy perspective is the yearly incident rate in these cases, and obviously for Hep C and Hep B, that was very strong in the yearly incidence rate. In the cirrhotic NASH, particularly if you have high FIB4, it's above 1%, so that's also a clear shot, but I mean, we're recommending to screen on cirrhotics. If you're non-cirrhotic in NASH, it drops to below 0.1%, which is something where you are not cost effective. Against German operating in a medical system where you want to offer something to the patient, we say you can offer it, but it's nothing that's backed by cost effectiveness analysis.
Duly noted. Then we'll move on to my highlights. I'll do family also. My wife and all the cousins of her generation had a family reunion this weekend in Florida, and I believe it's the first time that crew has been together not to celebrate a family event or for a family event. Funerals aren't always celebrated, maybe ever. Certainly not since I've known this family, and that's over 25 years. So we just had a great time. And then Tottenham beat Chelsea, which is something we never do. So that was just an added bonus. Rohit, I've given up on the idea that we're going to finish ahead of Arsenal this year, but we might make it into the Champions League anyway, which would put us ahead of Liverpool the way it looks right now.
Yes, but that was one of my second highlights of the week, to find out that Chelsea were below Liverpool.
Yeah, but you can say that about Brentford and Fulham also, right? In fact, Fulham looks like they're having about the best season a promoted team has had in a long, long time. At any rate, let me just start by noting that this podcast has never done an episode on pediatric and adolescent. And at this point, I've lost count, but we've done 170-something episodes. So that's a lot for this topic to have lagged that long. Every time I've wanted to do it, something's come up that's urgent. However, here we are, and I think this is appropriately urgent. As the global pandemic of NAFLD grows, so it grows in pediatric and adolescent. The population estimates are way, way higher than they were just a few years ago. Some of that may be better methodology, but I think a lot of it actually is probably a change in the reality of the situation. If you look at the diets that kids eat and the idea that no one gets as much exercise as they used to just to start, you have some pretty powerful social factors to predict that that those numbers will go up. Then on top of that, we have everything else we're looking at. Today, I'd like to spend 45 minutes really going through this topic. We've got some great people to do it with. And I'd like to start just by talking a little bit about prevalence and incidence and what the numbers are estimated right now, rate of growth, and what you folks who work with this see in those statistics or trends that people should be paying attention to.
No, it's a really important point, Roger. You mentioned that it could be that the environment's changed. I tend to agree with that. If you look back into the 1900s, we definitely did not have the environment in terms of easily accessible, low-cost, high-calorie foods, especially processed foods that we have now for our children. And when those are available not just in the home, but also at school, it multiplies the effect. And what we've seen is not just increased identification, which I completely agree can be part of it, but it's also, if you look at controlled cohorts, there's a very nice study that was published a couple of years ago by lead author Sahota in Pediatrics, which is the official journal of the American Academy of Pediatrics. And they had a controlled cohort, Southern California Kaiser system, and they followed the same cohort from 2009 through 2018. And the incidence rate per 1,000 went from 36 to 58. In the same cohort, with the same docs, same geography, you would imagine mostly the same population base. So I do think that there is an increased incidence. Why? We can all conjecture, but definitely there's an increased incidence.
This is interesting, Rohit. You're mentioning Kaisers, which means it needs to be coded. And I think there is an increase of coding, which means the numbers are probably higher. In pediatrics, on top of that, I think, my disclosure is I'm an adult physician. I don't see anybody younger than 16. The obvious codings are the ones that come in cirrhotic or HCC. Now, those are the cases we are coding as an adult physician, unless you are in a practice where you're really screening that, and that's like only a handful. So in the pediatric arena where you have fatty liver, and I don't think most cases advanced, there's probably even more of a gray area. I'm not sure what your take on that is or how we can extrapolate to the true numbers.
If you go even further back in 2006, Jeff Schwimmer actually did a much more finesse study to establish the prevalence at that time through biopsy studies. And he didn't go around biopsying children, but it was an autopsy study done on children who had unfortunately met a demise with a motor vehicle accident. So it would be, of course, completely random event, agnostic of who you are and where you live. So looking at that, there was already a very high prevalence of NASH and fatty liver disease. Completely agree, Jordan, that NASH would be the smaller component under that umbrella. So about 10 to 15% of those children had NASH, bona fide inflammation and or fibrosis. And actually about 2 to 3% had what some would call on pathology, but not on imaging, cirrhosis. So I think there is a component of susceptibility in the population where you overlay this highly dense, cheap nutrition of processed food and high sugar that we have all around us, the milieu, and you end up with children who have not only NAFLD, but also NASH and cirrhosis.
So, Rohit, I was thinking when you said 2009 to 2018, the two time periods that are etched in my mind are 2008, 2009, and then 2020, 2021. 2021, obviously the pandemic, which is about food and also about exercise. But 2008 and 2009, the Great Recession, from which a lot of segments never really recovered. So I've always believed, for exactly the reason you said, that this is a disease that should go hand in hand with food insufficiency. Because food insufficiency is what drives people to all these cheap, high-calorie, low nutritional value foods. So if you have, 1 in 8 Americans right now is defined to live in food insufficiency, there's a higher number among kids. It's not surprising that you would have pretty rapidly growing rates and that those would be two periods where things would jump up a little bit.
It's very interesting you bring those up. Definitely geopolitical events such as those make an impact. But there's been a slippery slope all along. I mean, the 36 didn't get to a 58 incidence. Every year along that timeline, there's been a slow and steady increase. Though we do have data from the pandemic, which needs to be investigated further, as published along the endocrinology pipeline, where having had COVID-19 infection has been associated with increased incidence of diabetes and beta cell dysfunction. And therefore, again, hand in hand with other metabolic disorders like fatty liver disease, probably. So much more work needs to be done, but I do acknowledge the geopolitical events you're talking about.
I completely agree with Dr. Kohli. I think there's increased incidence. What we estimate is the prevalence is probably around 5 to 10% in pediatrics. That early data from Jeff Schwimmer from San Diego was around 10%. There's some more recent papers, other geographic locations, New York State, for example, maybe lower, 5-6%. But once you go to adolescents, now we're talking about maybe 17 to 25% of adolescents with fatty liver disease. And the key is to understand this is not just NAFLD. These kids actually have NASH, and many of them have significant fibrosis. Most of the case series on the prevalence of NASH and fibrosis come from academic centers. Obviously, they had a biopsy, so there's a tendency to overestimate. But as Dr. Kohli mentioned, I mean, I've seen patients with NASH cirrhosis as young as 13 years of age. I'll never forget, I had a patient at the Cleveland Clinic. She was 13. She was heterozygote for something we call alpha-1 antitrypsin deficiency. So she has something called MZ phenotype, and she progressed to cirrhosis proven on biopsy by the age of 13. So I think it was, the combination of a genetic background, but the fact that she was severely obese, she had obstructive sleep apnea, prediabetes, dyslipidemia. If you looked at her medication list, she was on metformin and a statin, and she had a CPAP. So this is the reality. And we've published, it's been almost a decade now, I think 2014 or 15, a case series using the United Network for Organ Sharing, UNOS, looking at liver transplantation in adolescents and young adults. This is a group we call AYAs. And at the time, we found about 330 cases that were transplanted before the age of 40, including 20 that were transplanted for NASH before the age of 18. I mean, obviously, compared to the adult numbers, this is still good. But the fact is that the disease is starting earlier, and these patients are at risk of developing cirrhosis in early adulthood. There is actually a follow-up paper showing that if you look at these young adults between 18 to 40, that NASH is the fastest rising indication for liver transplantation. So definitely concerning statistics.
That's impressive numbers, Naim. And again, I don't deal with pediatrics, so I tend to kind of oversee that a little bit, and I don't know the numbers in the field so well. For me, I always think of the metabolic comorbidities. My patients are not metabolically healthy, but I imagine if you start being metabolically unhealthy at the age of 12, that must mean you get so much more trouble, not necessarily only liver disease, which takes more time, at least from what I see in the adult area. Do we know something about the incidence of metabolic complications, heart disease in these children, like in their mid-30s, 40s? Are they prematurely developing problems there?
Since you asked me about cardiovascular disease, I'm going to actually share a new paper that was just published in Gut by Dr. Tracy Simon, and I was one of the co-authors. And this is a paper that came out of Sweden. So in Sweden, they have this nice registry called Espresso, which is epidemiology strengthened by histopathology reports in Sweden. And basically, they have access to all the liver biopsies that were done at the 28 Swedish pathology departments. So basically, every liver biopsy done in the whole country of Sweden was available to us. And they looked at a period between 1966 and 2016, so over a 50-year period. And what we're looking for is really cardiovascular disease in patients that were diagnosed with pediatric NASH. So the age was less than 25 years of age, so we looked at some young adults also. And in that time period, we identified approximately 700 biopsy-proven cases of NAFLD and no history of cardiovascular disease, and they were matched to approximately 5 controls from the population without NAFLD. They're followed for about 16 years, and we looked at incident major adverse cardiac events. So this is defined as ischemic heart disease, stroke, heart failure, or cardiovascular mortality. The findings were very striking. So we found that in patients with NAFLD compared to the controls, that the risk of MACE, the hazard ratio was at 2.33, so about 130% increase in MACE events in patients with NAFLD. And there was increase in ischemic heart disease with the hazard ratio of 3, congestive heart failure with the hazard ratio of 3.9. And because we had biopsy data available to us, we were able also to look at NASH, and we found that patients with NASH had actually higher hazard ratio for MACE events at 5.2. So it seems like, having a more aggressive histology on the initial biopsy was also predictive of cardiovascular events. And finally, we also looked at cardiac arrhythmias, and there's a lot of literature now on the association between NAFLD and AFib, and there was actually an increase in the risk of cardiac arrhythmias in NAFLD compared to controls with a hazard ratio of approximately 3-fold increase. And I think what's important about this is that, as you said, as the disease starts earlier, as they have more years to live with NAFLD, that you start seeing these metabolic complications develop, and it seems like they are associated with the severity of the baseline disease. So having NASH was associated with higher hazard ratio of cardiovascular events than just having NAFLD. Again, we cannot be so liver-centric. We have to realize the effects of fatty liver disease on the other organ systems, especially cardiovascular disease. So I wanted to share that data with you guys. And this is, again, fully published now in Gut.
I was just going to highlight the step before we reach, Dr. Alkhouri, where there are children, adolescents, who haven't, even for the most part, not even reached adulthood yet, or undergoing bariatric surgery. And one of the ways the Bariatric Surgery Organization, ASMBS, American Society for Bariatric Metabolic Surgery, has lined up the thought process for why children at this age should be considered under all the right circumstances is because of the long-term metabolic consequences of obesity. Now, outside of fatty liver, which of course we're talking about today, the biggest thing that jumps up is cardiometabolic. And in cardiac events and cardiac risk factors for cardiac events before metabolic surgery in adolescents versus 3 years after, Mark Michalski and his group called Teen Labs, which was an NIH-funded U01 multi-center trial led by Tom Inge, they have shown that there's a reversal in these risk factors for cardiovascular events. Cardiovascular disease risk factors are completely night and day before and after bariatric surgery, or if you want to put it this way, weight loss.
Naim, can I ask? I thought that was a lovely paper. I just wanted to focus on the subtypes, the zones 1, 2, and 3. Dr. Kohli's done some work on that in the past, and it was particularly zones 1 and 3. Can you describe that to me? Because it's not something I'm familiar with being described in adults in the zones in the way that it's described in children. And although I've FibroScan children in the past, I don't now, but it's not something that I'm familiar with the way you describe the zones in this paper and the other paper.
I'm going to have Dr. Kohli answer this question for you. That's his expertise.
It's interesting. I mean, came out of large data sets. Actually, it was a collaboration between Cleveland Clinic when Ariel Feldstein was there. And I believe if you're talking about the same paper I'm thinking about, Carter Kent was the lead author. And we talked about inflammation more in the portal tract area of the hepatobiliary milieu in children. And why that focus is there, we of course don't know. But in children, this inflammatory foci being more portal-centric seems to be the case, and has been shown in other cohorts as well. Though I will say that this is not a given. There is some consternation, some debate even within the pediatric community if this type 1 versus type 2 NASH truly exists. But definitely it has been identified enough times that there's a discussion.
Just to add to this, so Louise, in pediatric NASH, especially in the earlier case series with Jeff Schwimmer, we noticed that there is less hepatocyte ballooning, and especially younger Hispanic boys, and more portal inflammation. Then it seems like there is a shift around the age of 12, 13 to more like an adult type where you see ballooning. And this has great implications if you're going to design histology-based pediatric trials, because you cannot count on the presence of ballooning despite what the pathologists will call NASH. And as you know, the resolution of ballooning is the hallmark of what we call NASH resolution. So if you don't have ballooning at baseline, how are you going to define NASH resolution? As Dr. Kohli said, this portal inflammation piece is overlooked in the NAFLD activity score. When we talk about the NAS, we look at lobular inflammation. We actually published a paper in the Journal of Hepatology looking at adding portal inflammation as a component to the NAFLD activity score. We developed a score called the Pediatric NAFLD Histologic Score. We didn't want to call it the Pediatric NAS because it sounds a little bit off. So we call it the PNHS. In that one, we proposed that you add actually 2 points for portal inflammation, and you take your NAS from 0 to 8 to now PNHS that goes from 0 to 10. Unfortunately, we didn't have a lot of data to kind of implement this in clinical trials and see if you can actually design trials based on this and calculate a sample size. So it's work in progress, but my hope is that we never have to biopsy children 2 times as part of a clinical trial. So the hope is that we can really translate the work and non-invasive testing from adult to children. But actually, I'm going to go back to Dr. Kohli and have him tell you a little bit about all the limitations in NITs in kids. We do not have the same amount of data. We still struggle a little bit with the cut points for significant fibrosis. We don't have much on diagnosing NASH based on NITs. In adults, we have a lot about fibrotic NASH. So a lot of work that needs to be done, but I'll hand it back to Dr. Kohli to tell you about some of the limitations and some of the promising aspects of NITs in children.
No, thanks, Naim. Just stepping back from NITs for a second, you touched on the pathology and the need sometimes in clinical trials to have a similar endpoint before and after intervention. It's interesting because if you look at the clinical trials that have been successfully completed and published in children for NASH, some of them tried to use histology as an endpoint, such as the TONIC trial. Then some of them saw the limitations of histology, such as you just very nicely outlined, and therefore went to liver enzymes. And there's been a whole 360 cycle, depending on the outcomes from the trials, which all unfortunately have not not been very successful, where you go back and forth between using liver enzymes or using liver biopsies. NITs, between the two, I think, large genres that they're there, specifically MR-based technologies such as MR-PDFF or MR elastography versus the more ultrasound-based transient elastography technologies such as FibroScan and the like. I believe each one of them has a little bit of a plus and a minus. When you think about the transient elastography methodologies available in the office point of care, of course, it's more accessible and it's easier to do. However, as soon as you have a little bit more of central obesity, there's published data behind this, you start to get less and less accurate in your readouts. And then, of course, normative data is hard to come by as well in pediatrics to begin with for both of these entities. When you look at MR technologies, of course, there's increase in accuracy, but now you're involving higher cost. And if you look at the earlier data, MR elastography seemed to be a strong signal. It came out of Stavra, Xanthakos, and the other individuals in Cincinnati. However, they themselves have now published data which calls into question whether MR elastography is the end-all and be-all of NITs in children. So we're still struggling a bit here. Even though I personally am using point-of-care transient elastography in our clinic, more probably as a prognostic marker for an individual patient, but to start to use it in isolation in a trial, I would struggle. I'm not sure what the other panelists think.
Yeah, I mean, just to add to this also, FIB4 is completely useless in pediatrics. We've published data on this. There's data from Korea. You cannot use FIB4 to risk stratify pediatric patients. Patients can have, FIB4 less than 1.3 and have advanced fibrosis and vice versa. And this is well established, even in younger adults, 20, 25. So you cannot utilize the AGA algorithm, the ACE algorithm. So that creates also issues for us in terms of risk stratification. As Dr. Kohli said, to design trials on FibroScan, we don't do that in adults, so let alone to do it in children where we have less data, just because of issues related to variability. MRI, there was a paper published by Miriam Voss and Jeff Schwimmer where they actually looked at patients randomized to a low-sugar diet versus just standard counseling. And they used ALT and MRI PDFF, and they showed nicely that, when you actually go on a low-sugar diet, you can reduce your liver fat, ALT. So I think this is very helpful for designing trials for metabolic drugs, let's say GLP-1 agonist, thyroid hormone receptor beta agonist. I think that could be something to look at. It becomes more tricky when you're looking at inflammatory drugs, fibrotic drugs, what would be an endpoint for you? And at the end of the day, just reducing liver fat and ALT will probably not be enough for the FDA to say that we have a drug that will be approved in adolescents. So we need something else. But we have some data on ELF, but we don't have longitudinal data, just baseline data, mainly from Italy. We have, again, limited data on FibroScan, more limited data on MRE. MRE has been great for baseline staging, but even in adults, we're not able to use it as a primary endpoint for non-cirrhotic trials. And now we're looking at it as maybe an endpoint in cirrhosis trials, but this is not going to be the case in pediatrics. Luckily, despite everything we said, NASH cirrhosis is still very uncommon in children. So a lot of research that needs to happen, and I'm optimistic because as we get closer to FDA approval in adults, every company needs to develop a pediatric study plan. They're having conversations right now with the FDA, with the EMA, but the picture is not very clear. Again, we don't have clear guidance from the FDA on what will be an acceptable endpoint. EMA also still asking for liver histology. So we need a little bit more guidance from the regulatory authorities because, again, we will see these adolescents that have significant fibrosis at an early age where we need to use medications that we use in adults. So we need to generate that data as soon as possible. And my hope is that we avoid doing repeat biopsies the same way we design now the phase 3 clinical trials in adults.
So Naim, I'm going to be a bit controversial. On average, it takes 17 years from a clinical trial to implementation in the real world. So we're talking about pediatrics and children in a vastly rising condition called NAFLD, NASH, childhood obesity. You've already, both yourself and Dr. Kohli, have stressed the cardiometabolic. Tracy Simon's evidence of 1 in 15 biopsy-proven fatty liver, not fibrosis, was dead in 20 years, so they're mid-30s. Do we have to not take a leap of faith as an observational study in some of the NITs? I don't know what FAST does in children, but do we not need to take the initiative to generate data to try and save lives? Because on average, 17 years, these kids are going to die. Now, I have never fibroscanned a child with a parent in the room who's not immediately changed the diet when they've seen fatty liver on that child's fibroscan. So we don't do family scanning, for example, but the behavioural impact, I just wondered whether or not you've got experience of that behaviour and how it motivates change. I saw an 18-year-old last year. He was one of 6 Indian children. He was nearly 300 kilos. He was massive, but he was 18, diabetic, and on FibroScan, his FibroScan was in the 30s, and it was beyond measurable in CAP. So any intervention that needed to go in wasn't just him, it was the family. Mum does the cooking for the other 6 siblings. He was just the one presenting to the clinic. So the controversy is, do we start to do non-invasive clinical data collection to see whether or not it changes behaviour, even if it does not prove a clinical diagnosis?
So I can speak to that a little bit. We're doing that in one sense. Our protocol, we've published it a couple of different times, iterations of it, clinical protocol, includes a liver biopsy if we have not been successful in just lifestyle management and producing weight loss in someone who has elevated liver enzymes and is obese coming to our clinic. However, once we have established the diagnosis, we want to pair that with a non-invasive test. And that's where our FibroScan and our MR elastography come in. And I found just similar experiences with you that this is a family affair, because at least early on, from the 10 to 14 age group, the parents are the ones that own the grocery cart. However, if we don't involve the children at that age in the same discussions about eliminating sugar-sweetened drinks, it's never going to happen. So I think these things are societal. We started that discussion early on. And when you make an impact, it has to be to the family. This is a family affair.
Louise has argued for roughly as long as I've known her that the long-term solution has to start in education, and it has to start in the schools, because if you educate the kids, ultimately that will trickle through to the parents, particularly where the kids have issues. Whereas if you start with the parents, A, you're going to miss the kids, and B, the parents won't take it as seriously for themselves. We're audio, so no one can see how enthusiastically you're nodding, Rohit, so I'm going to mention that. Louise, did I get that right? Or right enough? And then B, I'd love for colleagues to comment on that.
You got it right. And I think from my perspective, going back to where we started, cost effectivity analysis, if we start to screen children, we do their educational assessments. We should be doing their health assessments as well regularly. If we start pre-screening children and include liver health in the conversation, then we may avoid cardiovascular disease. And then it becomes highly cost effective to look earlier, not later, not looking at the cirrhosis level, but looking at the cardiometabolic and endocrine disease that comes out in these children. Therefore, we make it earlier in the timeline. We screen at an earlier age. I think it was Paris Nash or something. There was a Russian cardiologist on talking about the Russian system where they screen everybody at the age of 18. Then I think they intervene again at about the age of 35 and look where they've progressed to. So that's something that could be done, because fatty liver, as we know, is the elephant in the room in cardiovascular disease, endocrine, obesity. It is now getting more of a role and recognition. For me, cost effectivity starts at looking at the children, maybe from the age of 10, unless there's a particular problem below then.
Yeah, I completely agree. I mean, actually, the Pediatric GI Society for North America, NASPGHAN, we came out with guidelines that mirror what you're saying towards the end of your statement, which is once you are 9 to 10 years of age and you're going to your primary care annual physical, you should be checked for your ALT level. And the normative value, which is yet another story, of upper limit of normal for children is around 22, 24. Therefore, if you are 2 to 3 times, and you can debate whatever cutoff you want to use. But for me, if you're above 45, we need to pay attention to you, IU per liter of ALT.
That's great. And actually, I had 2 other items on my list, but Jorn, I want to know what you've been thinking since you've been uncharacteristically quiet.
Yeah, I've followed the great discussion and presentations, and again, not seeing pediatric NAFLD patients, I took back a little bit. And my thoughts go to the NITs. I mean, Naim made a good point in highlighting all the limitations of the indirect fibrosis surrogate scores we're using. And he mentioned that there's some data on ELF. I was wondering to ask about PRO-C3. Obviously, that's much earlier than ELF. It's not available for clinical routine. But I think the direct fibrosis markers might be something that's worthwhile looking at in pediatrics, being well aware that you need the funding to do this type of research, and there might not be as much interest in looking at fibrosis because it's more early disease and and metabolically burden these kids have. That's why I asked Naim about the outcomes. It does something to you if you have that inflammation from early on in your liver, and it might not mean you develop cirrhosis in all cases, but for sure it's the metabolic burden you start into life with is, it might impact cancer and all these type of things. That's my way to look at it.
Yeah, and just to mention that, there's some good work that's being done in the pediatric space, Luis. So the NASH Clinical Research Network, sponsored by the NIH, they have a large pediatric cohort that has been followed longitudinally. And then there's something called Target NASH, and I know they included a pediatric cohort as well, trying to understand the natural history of the disease, who's at risk of significant fibrosis. In addition to genetics, family history is very telling, right? If your dad has F3 fibrosis and your grandma died from NASH cirrhosis, you are at high risk. And, there was a paper by UCSD, Dr. Lumba and his group, looking at first-degree relatives of patients with NASH cirrhosis, showing about 15-17% will have advanced fibrosis. A lot is being learned about this age group. I think when it comes to trial design, my hope is that as we dissect the phase 3 data, let's say with resmetirom, with Madrigal, and we learn about correlation between reduction in MRI-PDFF and ALT and histologic response, that we can extrapolate that to the pediatric population and continue to generate more data. I'm not saying it's going to be the end of development of NITs, but, if we know that in adults, if you reduce your liver fat by 30% from baseline and ALT by 17 units, combined endpoint, that the chances of you achieving NASH resolution is 5-fold higher than someone who doesn't achieve this. Is this good enough for us to say in adolescence this is a sign that the drug is doing something? And I hope we do the same with obeticholic acid, which might be a little bit more challenging to use in a pediatric population given the pruritus increase in LDL. But maybe for some advanced adolescents that have F3 fibrosis, we can look at improvement in liver stiffness, potentially also liver enzymes, and look maybe at a combination NITs to predict response from non-response. Again, developing these pediatric study plans, having these conversations is very timely. You cannot get an exemption from doing pediatric studies for a disease that exists in pediatrics. So, there are diseases where you get an exemption like PBC. I mean, it's almost non-existing in a pediatric population. This would be a very exciting case report if you diagnose a 17-year-old with PBC. NAFLD is definitely a different story. And the last thing I want to say, as you said, Louise, the liver sometimes is the first organ where you can show the family and the child that this weight is actually harming you. We're not talking about how you look, or it's more about, your internal organs and the potential damage. And the liver is usually the first organ where you can demonstrate the effects of obesity. So I think doing the fiber scan is always a good idea. The question is how you're going to intervene. If the intervention is a lifestyle recommendation that you can have the family follow, that's great. I mean, there's no downside. If the intervention is a medicine, there's a little bit more burden on us to show benefits before we prescribe medications that could be potentially used for decades. Same thing with bariatric surgery. When it's indicated, I think it's life-saving for sure, but you have to be more selective and continue to generate data on long-term outcomes. When I was at the Cleveland Clinic, I was involved in a case with an 8-year-old who weighed 200 pounds. And basically, the court decided to remove the child from his family and place him in foster care. And that was the first case in Ohio that I was aware of. Because, in pediatrics, when you treat malnourished kids, you can actually say that, this is neglect and they're not being fed, and you can actually have the court involved. But that was the first case that the court got involved because of severe obesity to the point that they felt like this was child abuse. So 200 pounds at 8, probably we lost the battle with the simple lifestyle intervention. And as soon as he's in the adolescent age, maybe bariatric surgery is actually indicated.
Yeah, we've had a few cases of neglect for obesity. They just pick one or two. They don't necessarily do it consistently. And I think there's a problem with that sometimes.
When I hear a story about a population where the more severe the disease is, downstream, the worse the hazard ratio is, what that immediately says to me is fundamentally what we're dealing with is momentum. So it's like a cartoon snowball as it rolls down a very large hill, creates its own avalanche because the snowball just gets so big. If that's what we're dealing with here, where do you think we have the ability in advance of drug trials for pediatrics to intervene to either slow down or ideally eviscerate the snowball?
What I would say is it depends on the slope of the hill. And every child, because of their underlying genetics and ethnicity and family, have a different slope. So when you're talking about medications and surgery, that's a really steep hill. That means that children who already have F2, F3 when they're 13, 14 they need to be in the trial versus the ones that just have fat in their liver. They may develop diabetes and have other problems. I get it. But don't put them on antifibrotics and anti-inflammatories. They should be on a push to be lifestyle, family, psychology. Different strokes for different folks.
Rohit, just quickly, does that mean if drugs are approved in adults and not yet in adolescents, that you would see those kids going on those drugs anyway? The 12, 13, 14-year-olds with significant fibrosis?
Once they get to 18, who's going to stop us, right? So I'd rather find out which of those drugs actually makes a difference to the 13, 14-year-olds through clinical trials, but focus on that population when we do the trials.
Yeah, I completely agree. Obviously, medications are not going to be the answer. Luckily, the majority of patients, but there is that tip of the iceberg that progress fast, that has the family history, where we need to be aggressive. My hope is that we don't copy the trial design from adults and we get to be more inclusive in pediatrics. I think having any fibrosis in an adolescent is already alarming to me. So the hope is that we start at any fibrosis, so F1 or higher. Doing anything with cirrhosis in pediatrics is almost impossible. So I don't think you're going to see cirrhosis trials in children. So I think the target population should be F1 to F3. And my hope is that we also rely on non-invasive tests to identify appropriate patients and monitor how they're responding. I think potentially, the risk-benefit ratio has to be toward more benefit and less potential for harm in children because, again, they have a long life to live and being on a medicine for decades can potentially lead to downstream unwanted events that you don't necessarily see in someone who's starting the medicine at 60 or 65. But yeah, my hope is that we think outside the box, we come up with different trial design, and we are more inclusive in the pediatric population.
My thinking, and I hope Naim and Rohit and all these pediatric physicians involved or hepatologists involved in the care of pediatric patients really get to those families and educate them about the adverse courses we're seeing in adulthood, because I think this is really the arena of prevention, as Rohit said, not to target these kids with antifibrotics, and maybe fibrotic markers are not the best ones to be explored in them. You really have to take preventive measures here and try to get the whole organism retuned in terms of a healthy metabolism again. The examples you're saying, Naim, are extreme. I think at a much lower level, many kids are affected, and we really have to do something as a society. So for me, the pediatric arena is always preventing the wave we're seeing in adulthood. That's the way I see it as an adult physician, although I realize, they're very sick kids at a young age.
And just to add to this, since the liver is usually the first organ where you see damage, thinking about progression to type 2 diabetes is a very valid endpoint. Also, worsening kidney function, development and worsening of dyslipidemia. I think all of these things should be taken into account as we think about trial design in children. And I think these are very valid outcomes for this patient population.
I agree with everything that the guys have said. I think our biggest struggle is we are not quick enough in the context that technology moves so quickly. There's a figure out from Dr. Sandro Di Maio, the Australian physician, who's given an excellent lecture at EASL before, talking about Coca-Cola and all of the big manufacturers, McDonald's, and how they fight. And this figure, and this was Australian children who are probably less exposed than American children, but by the age of 13, there have been 72 million data points collected about that child. Advertising for use. How do we fight that level of harmful products, the e-cigarettes, the obesity, the junk food, all of that? How do we even cope with that to educate our children to be able to stop it? The speed that a trial takes. Talk about a tsunami. We know these figures are coming with childhood obesity, but it frightens me. So I can't disagree with anything that anybody said.
So, Louise, I'm going to go past that. I'm going to agree violently with what you just said, which is that there's an element of this that's screamingly a public policy problem. In the UK, you guys are fighting it a lot harder on sugar drinks and bad foods than we are in the States. We've had a couple of cities here take it on, but not any significant national or even statewide governments. We're basically feeding our kids stuff that's going to make their lives really difficult. And by the way, will make them less productive workers and shorten their lifespan and cost more money in the healthcare systems. So everything we talk about today says that on the science track, it's going to take time, right? Because we're not about to start prescribing drugs for kids when we don't know that there are no deleterious effects on a 12 or 13-year-old. But we know there are no deleterious effects teaching a 12-year-old not to drink so much soda, not to eat so much fast food. The things that we could do to affect advertising or what's fed to children in schools, we should be working on this right now because that's where we started in terms of what slid. That's the thing we could jump on tomorrow if we wanted to. And then everything else, I think will just take the time it takes, sadly. Well, thanks, everybody. I think it's been a fantastic discussion. I will be back in a couple of minutes with the business report. Rohit, Naim, Louise, Jorn. Look forward to seeing you next week. Well, look forward to seeing you two next week and them soon. Thanks, folks. Bye-bye now.
And now for the Season 4, Episode 10 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. As the second year of this war begins, I'd like to note the array of world leaders that have expressed the hope that Ukraine can win this war over the next 12 months and that we never see a third year of this war. As life continues day to day, though, Putin and Russia continue to attack key Ukrainian infrastructure with impunity, hiding behind the threat of nuclear weapons when he fears he may be attacked in turn. Slava Ukraini.
We've had some great responses to last week's Rising Tide episode and conversations.
Between last week's episode and the 4 conversations from Rising Tide over the weekend, we've seen over 400 downloads of Rising Tide content and have started to see subscriptions to the series. Here's a reminder. If you want to subscribe to Rising Tide, simply go to the surfingnash.com homepage and click the Rising Tide tab at the top of the page. You'll go to a page that offers 2 ways to subscribe to this series. Whether you choose the 1 episode or full experience option, you'll become a subscriber. And if you want to learn more about sponsorship, just contact me directly at rogergreen@surfingnash.com.
This has been a very big month for downloads.
As I record this late on February 27th, this is about to become the 3rd time in our 35-month history we will exceed 9,000 downloads for a month, which will be the 3rd largest month ever, despite being a 28-day month and this past week having somewhat lower than average downloads because of the Rising Tide demo. It's already our largest download per day month in history.
This weekend, we may have something special in place of our Vault conversation.
We were exploring replacing the Vault episode this weekend with new content closely related to our topic this week. If not, we will share an earlier episode that has Louise discussing in greater detail the public health benefits of educating children and or limiting advertising for unhealthy food products in the UK. Stay tuned.
Let's close with a question about reviews.
We've heard from several of you who report leaving reviews with your podcast distributor, but for whatever reason, those reviews are not making their way back to us. If you've posted a review, could you please drop me a note at roger.green@surfingnash.com so I can track why I might not be seeing them and keep them coming in. Thanks. So with that, I'm off for another week. Thanks to Jake, Magic Mike, Eric, Louise for helping us get this episode out the door, to our new team at Well Oiled Marketing, Nick and Allie and John, who are supporting us with some of our promotional efforts, and to everybody who's been part of this episode. Next week, we're exploring 2 different ideas. Whichever one we do not produce next week will come early in April. Until then, make sure to let us know how you feel about Rising Tide. Don't forget to send reviews. And then obviously, as every week, stay safe, surf on. See you next week on the podcast. Bye-bye now.
Have any questions for the surfers or a topic you would like us to cover in a future episode? Please write to questions@surfingnash.com. We'll answer your questions either on the podcast or the website, and we'll schedule a call or video conference to discuss your episode idea.